in that area. But we still have challenge with the sustainability. The government is insisting on school feeding, and the schools are trying to implement the school feeding programs, but always they fail at the initial stages. That was among the process indicators that we were evaluating. And as an implementer, and I have been asked to share some of the experience and the findings, as I have said, in terms of findings, that were the major findings of the study, in terms of overweight and obesity as one of the indicator, in terms of diet quality, in terms of nutrition knowledge. We didn't see much impact on terms of the micronutrient, especially the anemia, as it has been presented, that maybe the time for intervention was too short for the intervention. But based on the experience in the implementation, that we can say we achieved making sure that the schools that were in the intervention part, all the kids in the school received the school lunch, despite the fact that we were engaging only Form 1 and Form 2 in the study. But we made sure that all students in the school are having school lunch. It was not only designed for, the school lunch was not only for the classes where we are going to evaluate. And almost 90% of the schools received the school lunch in the time when we were giving this lunch. The very interesting experience is that the project didn't buy any food to supply to the school. All the food were contributed by parents. And this is the place where most of the schools fail receiving contribution from parents. But we were happy that the project succeeded to raise the contribution from parents. And also it acknowledged the level of malnutrition being high in school-aged children. And also it has given some of the policy statement, including the school feeding, but also the food fortification and the supplementation to be planned. Again, I went through the school feeding guideline that is given by the Ministry of Education. The school feeding guideline also directs on how these contributions can be received. It has the same model, but is asking the school to formulate the committee. Much of the responsibility have been given to the schools, and that's where we find maybe that could be the source of so many attempts of the schools to establish the school feeding to fail. So the school have been charged to be responsible for forming the committee, but also leading, although it is directing that the local government and all other part of the school board to be part of the school in the school. That we feel maybe that's where there is a challenge. We are recommending as part of the policy, maybe if we can review the policies that we have, the combination of intervention that we did. As we have said, our study was a pack of interventions, and we have seen it is working because the produce from the school gardens we are going to the kitchen to feed the kids. It also need to be emphasized in the guideline, but also we noted that usually the government directs the schools and the parents to contribute to run the school feeding program. But the way we discovered, we need a minimum amount to be injected in schools to support the school feeding program. The project was supporting minimum amount of fund. For example, when this committee, some of the villages are too far from the school. Some of the villages, you find it is almost 40 kilometers from the school, 30 kilometers from the school. They have collected the contributions from parents. Who is bringing that food to the school? Who is paying the cost of bringing that food to the school? But there were other costs like that of cooking oil, salt, tomatoes if necessary. Parents usually contribute staple food. So these were some of the costs that the project bared and then relieved most of the parents. Then when they contribute the staple food or they contribute the beans, then it was enough to run. Then also the project paid for the cooks and these agricultural extension workers, but was the minimum amount. So this, as part of the experience, I think can be taken to be included in the current policy and guidelines that we have. Thank you so much.
Okay, thank you so much. Erika Gore from Heidelberg University. So my question is to the second speaker, Dr. Kamanga. It's regarding the mega trials, so, and it was about the sustainability, because you spoke that you had the contributions from parents, and then from the project's perspective, you are paying the agricultural extension workers. But you say this is still a challenge. So in your opinion, how best do you want to go about the issue of sustainability? Because we've also had project where we are also thinking about sustainability, and it's still an ongoing discussion. So how best do you want to go about the issue of sustainability so that the project can live beyond your availability in this area? Thank you.
Okay, thank you so much for a very nice question about sustainability. And you have asked about the agricultural extension workers. Maybe let me correct this saying maybe we were paying actually was not as a payment but a transport cost. In my last comment I said maybe the way we think according to the experience in the implementation, the school feeding implementing as it is, depending on everything from the parent, especially from issues that are not direct to the food like transport and the other costs, may be sometimes difficult. But also these agricultural extension workers are working within the system. They are employed in the ward, so that means the government, that could be part of their activity, visiting the schools and helping the schools in ensuring the school garden. And we used actually the school garden as the, how do we call it, the demonstration garden, especially for the community. And actually these were documented again by the agricultural extension workers as part of their work in that ward. And I can assure you there are schools that are now implementing the school feeding and the school garden even after the project has phased out. So the project is sustainable. And that's why we didn't purchase any kind of food to take to the school, because we knew if you buy anything, that means that project, when it phase out, then everything will phase out.
Thank you, Moderator. Before starting, I think it will be wise to start explaining a bit about this Zafar Plus, just for a minute, so that we'll understand what is going on. Zafar Plus is a network of people living with HIV and AIDS, and this year we are commemorating 30 years since its inception. So it is a trusted partner within the Zanzibar, and it is a part of a health system of Zanzibar. So the network, it has roughly about 3,000 members, and we have headquarters in Puja and some another office in Pemba, but we have all branches in all 11 districts. And the Zafar Plus is a part of all platform or decision-making platform in the health sector. We are representing. So issues of nutrition, reproductive health, it's a core business for Zafar, because we know it's association with HIV/AIDS. So for all these 30 years, we are engaged into issues of nutrition and reproductive health. But apart from that, we are working with adolescents, the group that is we are targeting, and we have had the presentation from CDC. So Zanzibar, apart from conducting being part of this, we also did our own IBBS, the third IBBS, and also we found out the prevalences and incidences of HIV is very high, nearly double. But the new infections primarily came into this adolescent group. So starting from that, then we came to the partnership with a PH and a RISE network. That is also a privilege that ZAFA had. So now we have a broad base of evidence from all this RISE network group that we are also helping the Zanzibar in making their programs. Now, coming from the study that we have done in the last 2 years, we have learned a lot. And we also understand about the logistics, supplies, and all issues concerning the supplementation and nutrition issue. Now, the issue of scaling up and sustainability, what we have done. The good thing, the environment of Zanzibar is already been prepared for scale up, because the Ministry of Health is leading, and it's understood that we must have a collaborative effort and it must be integrated. So they develop a platform, and through the strategic plan, the fourth health sector strategic plan, the health policy, which is the draft health policy, the productive health strategy, which is just ending now, primary health care strategy. It's all these policies, they open up for scaling up of integration. So there are several strategies which we propose, because we are also a member of a community health technical working group, which is one among the 8 technical working group of Zanzibar Health Sector Secretariat. So we are contributing directly to this scaling up of what we have done in the recent. So the strategies what we are going to use. One is the capacity building, which we have already started, and also ZAFA was a part of implementing the great initiatives, which is also implemented in Tanzania mainland. We have already capacitated all districts. So currently we more than 1,000 healthcare providers have already trained in nutrition and reproductive health, and the community health volunteers are around more than 500 capacitated already. And the Ministry of Health, Ministry of Education themselves, they've also trained nearly 3 teachers in all secondary schools and the primary schools, all in Unguja and all over Zanzibar. So the scaling up is already started, and now currently there is another initiative of school-based programs and out-of-school-based programs, where we have about 90,000 adolescents out of schools where these programs, and we have 60,000 in school adolescents which we are having this program. So currently we are working in 180 secondary schools, but in a study we worked with 44 secondary schools, and we're still visiting them and still working with them. So the capacity building is broader and is continuing. The only issues we have about sometimes, the resources and something like that. But capacity building is. And the other one is the awareness. We know nowadays, especially in the supplementation, people are scared of swallowing, and it's school-based children is the same. So we have this awareness program. In ZAFA Plus, we have ZAFA, we call the Young Reporters, a group of adolescents, which they provide awareness for their fellow adolescents. They have their own studio, they are producing all the social media, all other things, and the website. So this one is the one also we are providing awareness to the adolescent about these projects, and we are having a project of parent-child communication, where we're targeting parents through their children to discuss about issues of reproductive health and the nutrition. Another strategy we have that to ensure that sustainability and scale up with the Ministry of Health, we I don't know which terms to say, but we modified a bit the logistic of supply. So the supplements is coming from Central Medical Store. It goes the usual route up to the health facility, either dispensary or health center. But from there, each health facility it has a school, nearby school, which every week they take the supplementation to school for children, and then they get the report and they get. So we are using the same system so that in the future there is no need to have another parallel system. Big supplementation if it is needed to schools. So that one we have started and it's going very well. We are still following up and to see how it is going. Also, MNE, we wanted to strengthen MNE so that we can get the information in these initiatives that is, and it should be sustainable. So for now, there are two MNE routes. One is the usual one from the health facility, where they collect all the information and then it goes up to the DHMT and up. And we have another route from the school. Now school also, they have their own information they connect because they have also their projects, gardening, cooking and something like that, plus the supplementation. Where there it also go to the district, but it goes to the educational sector. So Zafa Plus, we are helping it to coordinate this, because as you know, in Zanzibar, we had a decentralization and then now we have decentralization a bit. So the council is DHMT is vertical, go to the ministry. But we are building that the network, the MNE, so that they join it. And in the future, to see how the government is it can work this modality up and to see we have information and data from both sectors in one place. And the last one, but not least, about the issue of sustainability. So the government now, it wants the dispensary and the health center to have the finance of their own. They'll have a bank account and something like that. So that all this is in initiatives, they can be financed from the facility. So Zafa Plus again, we are in a technical working groups in this group that is developing this process, and currently also we are in another technical working group developing the training material and everything, so that the facility will be self-sustained, that at the same time also they can finance the communities around. There's a component of research which I said, and we are helpful to collaborate with the education. And this Samia is one of the research which we have started, and I hope we are going to have more research opportunity with the RISE network that we can inform the government. Currently, the Zafa Plus is finished building it. It's a CTC, and one among the things which we want to do at that place was to conduct research and to do some interaction from the center, but which is very soon we are going to put it into use. And now we remain with community engagement. That is our core business. For all these 30 years we are engaging with community. We have people at all levels, up to the household level, we are engaging with the community. I think because of a shortage of time, I think I should stop here, and thank you very much for listening.
And my question will be directed to Zafa Plus, Zanzibar Association for People Living with HIV. We understand currently the World Bank and the government of Tanzania have provided big fund for energy expansion in Zanzibar. whereas a lot of activities will be happening in transmissions, developing the centers for production of electricity by solar, by wind, and the extension of the electricity which is coming from the mainland. How are you prepared? Because one of the group which is going to be affected, because there will be a lot of demolishing and a lot of activities will be going on, influx of people from Tanzania, other countries, and we are hoping also the list of child labor to be happening, which will be causing also, especially adolescent boys and girls not going to school. How are you prepared to safeguard them, to protect them against HIV, exploitations, for teenagers' pregnancies, and such kind other indicators which we are discussing here?
This is a good question, but even before the World Bank, the support, if you go to Zanzibar in the last 1 year or 2 years, you will see it's construction everywhere. Roads, we have built already 10 hospitals, one district hospital, one regional hospital, more than 2,000 rooms. Everywhere is a construction area. I don't know much about the other sector, but the government asked us to write something or to propose something on all this development. On our side, ZAFA Plus was a part of a panel of a technical working group that will develop the guidelines for HIV prevention and care for all these projects. And now it's mandatory for all these projects that should have the component of HIV and care. And also we are part of the technical working group who are reviewing the proposal. But I don't know for the other sector, because I don't know what is happening there. But I know the government is taking care.
Thank you very much. Thank you for giving me this opportunity to speak a little bit about what is going in Burkina Faso, the landscape of the adolescent and youth health. To say, as the others, I believe the most of policies and programs targeting adolescent and youth target this population from 10 to 24 years. This is already something to say that the adolescent age group, that is 10 to 19, is a little bit diluted in this group. But in the other hand, you know, we have these groups that is the 6 to 9 years. Most of the time, there is no program that is addressing this group. So in Burkina Faso, the policies try to really get this group as well as part of the adolescent and young group. And this make even broader the group and dilute it further the action that is going to the adolescent group, as I say. And the adolescent people in Burkina Faso is represented 1/3 of the population, which is roughly more than 7 million people, which is quite a lot. And 3 adolescents out of 4 live in a rural area. This is really a strong statement to make. And besides this one, half of them are out of school adolescents. Meaning that all the program and project need really to think carefully how to reach out to this adolescent, because the easy things to get to adolescent is to really get them at school. But you have half of them that are not really attending school. This is really something need to be considered. As far as sexual and reproductive health is concerned, they also have early marriage. If you take the adolescent for 12 to 24 years, it's like 1 out of 10 male get married between 12 and 24. And if you go to the female, it's 1/3, 35%. We also have a high likelihood of induced abortion between the adolescent 15 to 24, which is 65% when you compare to the other group, 15 to 49 years, which is 41%. And adolescents in Burkina Faso are also involved in violence, let's say in this terrorist war that is going in Burkina Faso. Most of the people involved in that are adolescents. That make also very tricky, the adolescent health and nutrition issues to address. As far as nutrition is concerned, if you take the adolescent between 15 to 19 years, 1 out of 5 are undernourished, underweight, 1 out of 5, and 1 out of 10 are overweight or obese, which is also something really critical to consider. If you take the adolescent between 15 to 24 years, half of them has anemia. So these are really strong statements. We have also high prevalence of unhealthy eating with fast food, sugar beverages, alcohol intake. That is really also a growing problem coming to Burkina Faso, and the substance abuse. Within the different studies that we were able to conduct within the area or within our health and demographic surveillance system, we realized that this phenomena, like substance abuse, was first prominent in the urban areas, but now it's getting really to remote, to rural areas, which is really something that needs to be tackled very quickly. But out of this landscape, we have some good news. First is that there are policies in place. From the government side, we have policies. We have a multi-sectoral nutrition policy that try to consider the safety, food safety, water and sanitation, and also social welfare. These are the key points that are there, and this is also added with a national strategic plan to follow up the policy. We have a national strategic plan for adolescent health. I might say that this is the only document that really target only adolescents, because the others document, policies and programs, they are very broad. Even those inside you have chapters that are related to adolescents, but not really a single a specific document targeting only adolescents. And this is something really to take into account and need to be improved. And we have interventions as well. Programs like iron and acid folic supplementation, MMS supplementation, and even also the school feeding program. So these are good opportunities that are in place. And in the other hand, we have a governance body. If you look at the governance body.
Hi, Wafai Fauzi from Harvard School of Public Health. It's a question to many people, but particularly to Professor Mosa, around the issue of, I like the concept of moving from curative to preventive, and you mentioned platforms such as schools and community as two such platforms. And I wonder if you could comment on how to go about that. So in schools, particularly from the perspective of human resources that are necessary to be effective in sort of doing these preventive services. In the context of schools, do we tap into the existing teachers who are already maxed out, or do we hire a new cadre that supports adolescent health in the context of schools, be it nurses or be it other cadres? And at the community level, community health workers are also overwhelmed. To what extent are we able to sort of keep adding to the list of things that they do to include adolescents?
Okay. I think I didn't get a direct question to what I say, but I would like to add a few words to the question asked by Wi-Fi, because I fully agree with Mosa when he said that we have to, for the implementation platform, to move from the schools to the community. And I fully agree with this one. We hear from the keynote speakers, Professor Ayo, that it's about numbers. We have a lot of people, adolescents that are out of school. So for sure, getting intervention to be delivered at school is the easy way to get it done. But to reach as much people as possible, we need also to move to the community to do that. And to my view, what we can do for first delivering at school, you know, most of the health facilities, they have this outreach program going to the community and getting the intervention done in some point in the village. This can be also used at the school level, considering school like a village where we can have an outreach program going to school and doing that. And for this, I think the health workers will be the key actors to do that. And the school teachers and director should enable the process really to be established at school level. This will be my viewpoint for the school level delivery. And from the community, the outreach system could also be used with the health workers, but also the community health workers. If I take the example of Burkina Faso, we have community health workers already distributing drugs for deworming, for preventing malaria. They are already part of this team that deliver drugs in the community. We can use this channel as well to deliver the health intervention to youth at the community level. But one thing is important. Everything we have to do is really to support it with strong evidence, to convince the young and adolescents that it's really work for them, and to get them as well engaged in the process, so that we will really succeed with the intervention that we have.
I want to frame my thoughts around capacity first on the basis of the changes in the nature of the problems that we are seeing, and suggest that we are not prepared to deal with these kind of problems because our tools are old, based on the problems that we have faced before and that we are familiar with, and that's where we are comfortable. Let me give you an example. With health, and the way I'm explaining this approach to health is based on how our ministries of health are organized, and the philosophy that is dominant, which is very much based on reacting to an acute problem, a curative approach, right? When you think of nutrition, most of what we know around dealing with nutrition is based on nutrition in children under 5. And when you talk about anthropometric measures, and this is one thing I like about those babies, when they are sick, they will show you. You will know. And when you act and respond and you give them care and treatment, they respond. Can we say the same about adolescents? Do we really know what happens with the 6 to 9-year-olds that Ali referred to the same level that we have for the children under 5? We are so used to a curative model that it's hard to even think of a preventative health promotion model in our Ministry of Health. In fact, when you now add some of the behavioral, mental health, social problems that we see linked to adolescents in terms of their overall needs for health, within the Ministry of Health, we are not capacitated to deal with them. In fact, we draw from colleagues in social development and education and other places that have the tools and the resources to help us respond to the challenges that we face with adolescents. But again, our system is not organized for us. It's fragmented, right? It's not organized for us to interact with them. I've brought with me a colleague who is a director in social development because we have to strengthen those relationships and find new ways of working together. In so doing, we have to come up with new approaches and new tools. that are multisectoral, that are integrated, that are helping us to respond more holistically to the needs of adolescents. At the moment, we can't. How are we going to deal with the issue of teenage pregnancy, HIV, substance, behavioral issues, and other things all concurrently when our health system is not even designed like that? Let alone the fact that the rewards that we give in health management and healthcare are based on us curing a disease or an infection rather than us preventing an infection. If you come to me and say, I want to invest, which is really the word that we are using when it comes to adolescent health, and it is appropriate, I want to invest in adolescent health, you are asking me to put in resources into activities, work and program that are based on rewards that I'm going to experience in the future, not now. Outcomes that I'm going to see the benefit of in the future, not now. But I have to account, Doc, I have to account and demonstrate those indicators and outcomes today, because our system is based on annual targets, it's based on, if it's long, it's based on a 5-year strategy or program. That's the best, that's how far we can go. But with your notion of demographic dividend, with your notion of healthy longevity, and all of these things that we need to be aiming for, and approaches that we need to be adopting when it comes to adolescent health, we are not designed for them. What is the right platform to reach adolescents? Is it in the clinic? Most of us know that it's not in the clinic. The best we've done is go to schools. But when you've got low levels of school attendance or dropouts and so forth, then where do you go? Then you've got to go to the homes. But we don't necessarily think of the homes as a suitable place to provide health, because that's not how we are organized, and we don't even have the resources or the capacity to provide care in the homes in a way that might be suitable for them. Let's not even go to other platforms that the adolescents themselves would prefer, that are unfamiliar territory for us. So it is becoming quite challenging for us to tackle the problems of health and well-being in adolescents based on the same tools that have worked before, that we are used to. And when we get into spaces where we try to convince decision makers about the need to define the problem differently and arrange the systems and the capacity differently, it is a hard sell, because you have to sell something that they will not necessarily reap the benefits of during their term of work or office. But they are the ones that are holding resources. So my point here is that in the way that we think about building capacity, we've got to build capacity in a way that is suitable for the approach that we want to adopt in dealing with adolescent health and well-being. And we have to be forward-looking, and we have to be selfless. Forward-looking in the sense that we are dealing here with the need to protect the demographic dividend. You know, when we think about adolescents becoming healthy adults and them contributing to society and the economy, we think it's a given. It's not. On Tuesday, we were looking at the census data for South Africa, and we focused in on our province of KwaZulu Natal, and the people from State South Africa were presenting. And they showed us that in KwaZulu Natal, we've seen a shift whereby, unlike Tanzania at the base where you've got high levels of birth and a lot of children, we are now seeing the transition where the group that is supposed to be economically productive is now bulging out, right? Which is good generally in terms of development. But the economy right now cannot absorb them. Most of them are unemployed. Many of them are not well. So someone said, we don't have a demographic dividend, we have a demographic disaster. So we must not take it for granted that what we are going to end up with is a demographic dividend. The risk of demographic disaster is very high in our context. If we are not necessarily going to make a choice to approach the issues around adolescent health from a place of protecting the demographic dividend in a way that is selfless, that we may not necessarily benefit from. We are not the ones who are going to say, yes, we can demonstrate that we have had impact. People who are going to come after us are the ones that are going to demonstrate that. So, Doc, I just want to say that for me, I'm in a place where I think we are at a point where if we don't act now, then we are not necessarily going to see the same benefits for our adolescents as they grow up in the future that other parts of the developed world are seeing, because our context is different, our challenges are different. We are not going to see a demographic dividend, we are going to see a demographic disaster. We can't keep adopting a curative model that is focused only by a problem that for adolescents is defined purely because we can see teenage pregnancy, we have to address it. Or purely because we can see HIV, we have to address it, yes. Or purely because we can see substance, that we have to address too. But we've got to prevent problems from happening before they happen. That's the best way we protect the demographic dividend. Thank you.
Hi, Wafai Fauzi from Harvard School of Public Health. It's a question to many people, but particularly to Professor Mosa, around the issue of, I like the concept of moving from curative to preventive. And you mentioned platforms such as schools and community as two such platforms. And I wonder if you could comment on how to go about that. So in schools, particularly from the perspective of human resources that are necessary to be effective in sort of doing these preventive services. In the context of schools, do we tap into the existing teachers who are already maxed out, or do we hire a new cadre that supports adolescent health in the context of schools? Be it nurses or be it other cadres. And at the community level, community health workers are also overwhelmed. To what extent are we able to sort of keep adding to the list of things that they do to include adolescents?
We speak slowly in Africa. I agree with this point. I think that you need to convince me that you need a health professional for anything else except when you have to do a clinical diagnosis or review of diagnosis or prescription or surgery. Other than that, I think you can actually work with a whole lot of other groups. That's one. Two, I agree. I think that for me, we need to allow community health workers. But in health, we've got community health workers. In education, we've got community educators. In social development, in agriculture, we've got all these people. We also have a problem that people who finish school in my province is only 40%. There's a 60% people that don't finish matric. We don't know where they go. And this is the 18 to 25 age group that is loitering, contributing a lot to crime. So let's bring them in to participate. But also, besides participation of adolescents, let's get the adolescents themselves to drive programs. to drive programs themselves. And we support them to do that. And I'll finish by saying that we also just have to create new platforms, including in places where we can't reach. We just set up a new demographic and health surveillance site in an environment that is considered high crime, where when you speak to adolescents, my team, when they go and speak to adolescents and they're trying to collect data, they're saying, are you reporting to the police? I will shoot you. So they have to contend with that, and those places also we need to be able to reach.
I want to start with the policy mapping that the Arise, Nutrient and Dash partners did a few months ago. When I looked at the documents from the different partners, I noticed that most of our African countries have made significant strides in developing policies that target adolescent health and nutrition. I mentioned a few of these policies that we have in Nigeria, for example. We have the National Policy on Adolescent Health and Development 2020 to 2024. This is a very comprehensive policy that focuses on physical health, mental health, social, sexual and reproductive health, and social well-being of adolescents. So this promotes a multi-sectoral approach and outlines specific strategies for intervention. We have the National Strategic Framework also on health and the development of adolescents and young people, even though it is outdated because it was from 2007 to 2011. But it laid the foundation for the current policies that we have on adolescents' health and nutrition in Nigeria. The other one is the National Policy on Food and Nutrition 2020. And the policy acknowledges the specific needs of adolescents and aim to achieve optimal nutritional status for all Nigerians, including adolescents. The latest and the last is the National Reproductive Maternal Newborn Child Adolescent Health plus Nutrition, the RMNC AH plus N strategy, 2018 to 2027. And the strategy incorporates adolescent health and nutrition into broader reproductive and child health interventions, aiming to improve access to services and address adolescent services. But you see, despite these giant strides, a lot of gaps exist. Some of these gaps include a lack of a comprehensive national policy specifically focused on adolescent health and nutrition. And this leads to fragmented and uncoordinated intervention. The first one, or the last one, let me start from the last. The National Reproductive Maternal, Newborn, Child, Adolescent, and all that. It's not specifically focused on the adolescent. And even when we have these adolescent health policies, they should also, be kind of segmented to cover the spectrum, the whole spectrum of adolescents and youth. We have the early adolescent, we have the mid, and we have the late adolescent. So these policies should be specific enough to be able to target every segment of adolescents. Other issues include inadequate funding and resource allocation. There are knowledge gaps also. There's a lack of robust data on adolescent health and nutrition indicators, and this makes it very difficult to track progress and tailor interventions effectively. But thanks to the Arise Network, because the Arise Network, since inception, has made significant progress in collecting data on the different aspects of adolescent health. At least we can say that in some of these, in most of the Arise countries in Africa, we can have significant data on adolescent health issues. There is also insufficient research on the specific needs and challenges of adolescents in diverse Sub-Saharan African contexts, and this hinders evidence-based policy and development. There's inadequate awareness and understanding of adolescent health and nutrition issues among policymakers, communities, and even adolescents themselves. And where they exist, there is weak implementation and monitoring. There is insufficient mechanism for monitoring and evaluation. There's a lack of accountability also for stakeholders, and this limits the impact and sustainability of most of these interventions. There is also, so many people have talked about community engagement and all that. There's limited community engagement and participation in policy design and implementation. I believe policies on adolescents should include these special stakeholders. They should be carried along in designing these policies. Thank you.